that obviously we were talking about OLIF ATP, which practically like ALIF, you have a huge cage, and that the significant correction of lordosis is very representative. And I'm happy to hear that your number, about 2.8 degree, very representative as well for my experience so far, 2 to 3 degree. And certainly with a smaller cage, the correction will be as well limited. So in the last segment, I'm going to talk to you about some advanced technique. People ask me about the indication for transcambing OLIF. And before we get there, I want to tell you that the experience that most of us had here, thank you very much, that experience is that there is no procedure without side effect, there is no procedure without complication, and once you start doing that, once you go to your community, we are still the minority. People who have 10% permanent deficit will criticize you for your 10% temporary deficit. Let me repeat that. Once you start doing that, I don't care in what community, people who have 10 to 20% permanent deficit will criticize you for that 10% temporary deficit that we all had when we started doing this procedure. So you have to be prepared to gather your data, show that they are temporarily, and as well advance your technique, get more used to it, and based on how many of these advanced tools you have in your toolkit, then you can increase practically the number of the cases you can do safely. Now, these slides are going to be many different advanced techniques, but I want to concentrate only on one of them to stay within the time. And that is the so-called the transfacet OLIF. We are familiar with the anatomy. I'm not going to go through all the preliminary thing. I'll just concentrate on maybe a video. You understand, we get there, we do the discectomy, and what's important, the same tool is used. People who have done prolateral, they know the regular prolateral, just the retractor system comes in 2 boxes, 2 big boxes. Yet, not prolateral, again, this is all you need. So, and in the advanced technique of so-called transfacet, which we published a paper just last year, practically you are drilling the hypertrophied part of the facet, and coming back to you, Aaron, you can do discectomy. You can do a very good discectomy. So, and again, here you see the position of the cage is not by chance. It's eccentric to correct for scoliosis. And I'm just going to jump fusion and so on. I'm going to jump literally to the so-called transfacet approach. And there is a video. Instead of talking about it, I just want to show you the video. So here it is. In the transfacet OLIF, practically what you are doing, you're using a step drill to remove the lateral part of the facet, which is practically not the actual facet, it's the hypertrophied part of the facet, to get approach to cambium triangle. Now again, I know there are lots of words used for this procedure, and for my take on that is, as long as you do it transcambium, call it endolif, call it tubular T-lif, call it K-lif, call it O-lif, and so on. The name doesn't really matter. What matters is that you are literally using cambium triangle. In that case, you will be in the retroperitoneal space. In that case, it is what Dr. Cambium described it. Approach extraforaminal through the cambium triangle, which, by the way, it is not foraminal. Your entire surgery will be outside of the foramen, so it is not really a T-lif by definition. But in this case, practically in a 2-step drill, we identified the trajectory. You will see the x-rays. I have enough time to show you entire video. We fixed a small drill in the AP and lateral to a trajectory that takes you from the facet all the way to inside of the disc. Then we drill this trajectory, and by the way, we are neuromonitoring this. This is, again, you cannot do this surgery without neuromonitoring. At this point, I'm stimulating at 10 to 12 milliamp. I used to do 12 milliamp. Now I went down to 10 milliamp. So this entire process with small drill, big drill and tube stepwise following each other is done under neuromonitoring at 10 to 12 milliamp. Once you do this stepwise drill, practically you have established a path through the cambium triangle from outside to the disc. Now, your advantage is, this really doesn't show it, the advantage is that the axilla of L5S1, by the way, 90% of my transfacet OLIFs are done in 5S1. This is one of my rescue techniques. I tried the OLIF, if it doesn't work. I tried the MIS-DLIF. If that doesn't work, I do use this technique. So the last time I had to convert the OLIF case to open case was 4 years ago. I have multiple backup techniques to use that. Now, here, you see once we are in the place, then we use the regular technique. You see the stepwise, the small goes in. Again, neuromonitoring is done. And if you don't get a response at 10 milliamp, your safety profile is the same, exactly the same as regular OLIF. So the small drill, the big drill, and the tube, they follow each other. And Varun, this is one of the next thing I'm going to bring you next time I come here, because this is very easy steps, and it's a small, both cannulated, all cannulated, a small drill, big drill, and then the tube follows. And then once you are there, the rest of the surgery, obviously, exactly you don't want that happen in the actual surgery, but it won't, because there's a tissue that holding it back. So, but for demonstration purpose, let's look at actual X-rays. There's only a few minutes left here. If I have time, I just want to just show a video of the transfacet OLIF. It takes less than a minute. So these are the X-ray view of the procedure. So here you're going to see first, I do try the regular OLIF. So I have 1 minute time. So, but I'm going to go forward. Once I fail to find the electrophysiologic silence area, then I literally put a small drill. I fix the trajectory in AP and lateral that I get in the direction of the disc. And then the first, you will see that I dilate. Then after that, I'm going to forward. This is probably still our old system where I use a drill and a dilator, stepwise, drill a little, tap the dilator right next to it. Drill a little, tap the dilator next to it, until you are in the, or through the facet. Here you see that again. Once you are through the facet, then I put a K-wire, put a dilator, and I go in, and the rest of the surgery is the regular OLIF. Now, with the new system, the small drill goes all the way in under 10 to 12 milliamp. Then the big drill, again, on the neuromonitoring, goes all the way in, and the tube follows. Now, what you need to know about the anatomy of the L5S1 is that you have practically S1, S2, S3 already separating. They don't come straight down. They come in and go up before they go through the S1 foramen, and L5 goes lateral. So the axilla of the L5 and S1 is a ginormous space. And in the AP films, you see you are very, very medial. There are two things important. You are neuromonitoring it. Don't be afraid of that. Even though you look medial, the nerve root, you're not pushing the nerve root. The nerve root is above because it's taking off, going up because of the slope of the sacrum. and then obviously the L5 is very lateral. And another thing what's important, because you are going straight down, you can go all the way forward and put the cage in the middle, right in the forward, which as well helps you with some of the lordosis, okay? So thank you very much.
Yeah, thank you, Dr. Abbasi.